made it over our web page. So I am putting the recording for all the audience who will be listening to your clinical expertise. So good evening, everyone. We welcome you to the IVL Unplugged session. IVL Unplugged is a knowledge, experience, and peer learning session where the senior consultants they come together on a single platform and discuss about the complex challenges they face while treating the severe calcified coronary arteries. So today's session's moderator is Dr. Damodaran. Sir is senior consultant interventional cardiologist at Apollo Main Hospital, Grimshaw, Chennai, and sir is presently a fellow. Sir has over 2 decades of expertise, currently serving as head of department and senior consultant, as well as the fellow of European Society of Cardiology and Cardiovascular Angiography and Intervention Society, which we call as 𝐔𝐧𝐩𝐥𝐝. Sir has performed thousands of diagnostic and interventional procedures with special expertise in complex PCI, chip PCI, and sir is a respected academician and faculty at as well as multiple time gold medalist and award winning, and has presented widely his papers at global as well as national forums. Sir, the over to you now.
Yeah. So, Nishant, my humble suggestion is
Yes,
you
sir.
can go ahead with further with the session.
Sure, sir.
I have two of my colleagues, senior colleagues, Dr. Madan and Dr. 𝐔𝐧𝐻𝐥 with me. They're all well-known, renowned senior interventional cardiologists. Madan is from MGM and Dr. 𝐔𝐧𝐻𝐥 is from Apollo. We have eminent speakers who are all very well experienced. Dr. Sralin Roy, Dr. Selva Ganesh, Dr. Muhammad, and one more speaker is to join. I think Dr. Meenakshi, I don't know whether she is joined or not. With this, we can go ahead, and the first speaker is Dr. 𝐔𝐧𝐻𝐥. Yeah. Dr. 𝐔𝐧𝐻𝐥, you can please go ahead.
Yes, sir. Good evening to all. Am I audible?
Yeah, audible.
I will share the slides.
Yeah. Slides are not visible.
The slide visible, sir?
Yeah, go to the presentation mode.
Presentation, yeah. So good evening to all. Good evening to moderator Dr. Damodaran and Dr. Madan Mohan and all my friends. So thanks to the Translumina IVL team for organizing this webinar. So I will talk about the role of IVL in nodular calcium. So we all know that among all the calcified subsets, a non-eruptive calcified nodule is a very difficult subset to treat, specifically with what atherectomy we need to do, what is the mechanism of action to reduce the volume. All these things will come into the mind when we deal with nodular calcium. So we all know that not all calcium is same. So we often deal with superficial calcium, deep calcium, calcific plates, concentric calcium, eccentric calcium, calcified nodules. So these are the different types of calciums, but we will specifically look at the calcified nodule, that too specifically non-eruptive nodules, because the eruptive nodules sometimes will have at the base lipid core. So most of them, the eruptive nodules can be easily treated with conventional balloon-based therapies also. But this non-eruptive calcified nodule is a difficult subset to treat. So generally it is being debated whether for non-eruptive nodule we need to do, if it is not tight, there is a lumen, there is a way to go, whether we have to use orbital atherectomy or whether we have to use the IVL. And if the lesion is too tight, we may have to use two therapies. So we need to use rotational atherectomy to make sure we create a way for the therapy to go in, whether it is orbital or whether it is IVL. So the different therapies have different mechanism of action. So what we have seen in a nutshell is, in the balloon based therapies, we are depending upon the hydrostatic force. So in the whereas atherectomy and IVL, they do not depend upon the hydrostatic force. So the balloon based therapies typically have the hydrostatic force which breaks the calcium, and they do not target the calcium. Suppose if you are inflating the balloon, on one side there is a nodule, on the other side there is a normal vessel, we can rupture the vessel at the normal segment. So they do not target the calcium. So these are the two disadvantages of the balloon based therapies. They only act with the hydrostatic force, they do not select the calcium. And they can sometimes modify the deep calcium, but superficial and calcified nodule may be difficult. But they do not depend upon the wire bias or the lumen size. So this is the advantage with the balloon-based therapies. In case of atherectomy, whether it is rotational atherectomy or whether it is orbital atherectomy, they also do not depend upon the hydrostatic force, and they can target the calcium depending upon the wire bias in rotational atherectomy. And because we have the orbital movement in orbital atherectomy, two kinds of forces act in orbital atherectomy. One is the sanding, other is the pulsatile force. So this is with atherectomy. But if you look at the last column, IVL, they do not depend upon the hydrostatic force. This is specifically not a balloon-based therapy. So there is a misconception. We use the term called IVL balloon. Basically, it is an IVL catheter which has emitters which emits the shock waves to modify the calcium. So they do not depend upon the hydrostatic force of the balloon. Balloon is only used as a medium to deliver the therapy. And they have a specific target on the calcium because soft tissues allow the waves to go away without any disruption, and it is safe on the non-calcified part of the vessel. So they do not cause any injury to the non-calcified segments usually. And they can target both the superficial and deep calcium. That is another advantage. And they work independent of the wire bias and independent of the lumen size. Specifically in orbital atherectomy, we cannot use it for smaller vessels. So here it does not have this kind of a limitation. So the mechanism of action, we should be clear that IVL is not a balloon-based therapy. It is only a shock wave therapy with an emitter inside the balloon. So in conventional balloon angioplasty, hydrostatic pressure is modifying the lesion, whereas in IVL catheter, the emitters emit an electric shock which creates aquatic pressure waves, and these pressure waves need a fluid medium between the balloon and the vessel wall. So if the fluid medium is not there, we can deliver dry shocks which can damage the vessel. So basically we need to go at lower atmospheres. It is 3 or 4, or even we can have the delivery at 2 atmospheres also, which makes sure that we have a fluid medium between the balloon and the target calcium. So these waves spread across and can hit the calcium, break it, and then can reverberate back into the opposite wall. So when IVL was introduced, the main therapy was directed at concentric calcium, where the waves can hit back and forth and can amplify. So this created a notion that it may not be effective in non-concentric calcium like calcified nodule, or when the calcium is non-concentric, limiting less than 270 degrees of calcium. So how to effectively use the shock wave? The one important thing is we should not undersize the balloon. So the main problem nowadays is even when we are using in the initial days, we always used to undersize the balloon. But the important aim is to deliver the balloon at appropriate size. So always choose appropriate size or bigger balloon. But when you are using a bigger balloon, you can use lower atmospheres, 3 atmospheres, 2 atmospheres to deliver the therapy, because we need a little bit of a fluid medium. So always size appropriately. When in doubt, you can go for a higher balloon and go at lower atmosphere. So this is one point. Second important point is the emitters are the one which we need to position at appropriate place. Specifically in balloon-based therapies, we make the balloon at the center of the lesion and then we deliver the therapy. Whereas here, the balloon should not be centered. The emitter should be at the appropriate place. So we have to make sure we do this stent boost and then make sure that emitter is at the appropriate place whenever we are treating non-concentric calcium, specifically non-concentric calcium. So IVL, the perception is when it was introduced, it was effective in concentric calcium but ineffective in eccentric and nodular calcium. This was the perception. But the reality is it also acts on the nodular calcium. So the DISTRUBT CAD trial has proved that it has shown effectiveness in all types of calcium, specifically nodular calcium. And in peripheral angioplasties, in peripheral IVLs, usually what they do is oversize the balloon by 10% and lower inflation 2 to 4 atmospheres. This is being now slowly, not entirely slowly being followed up in the coronary vessels also. The important thing is the IVL sound wave safely travels the soft tissues, and we don't have much problematic dissections or vascular injury to the softer tissues. That is why the safety of the IVL is demonstrated in all the trials. It should be always 1:1 or sometimes oversized in case of nodular calcium. So specifically coming to the nodular calcium, nowadays the important concept which is being propagated is the pillowing of the calcium nodule. So you gently oversize the balloon by 0.5 millimeters and inflate at 2 atmospheres, which creates a pillowing effect. Basically, the balloon is advanced distal to the calcium and then slowly moved back, but we have to cover all parts of the calcium, and lower atmospheres has an effect of hugging the entire shape of the eccentric calcium. Most of the time the calcium breaks at the points of weaker, even though the calcium is different densities. It is being now known that the calcium breaks at where it is a lower density. It is not the thickness of the calcium. Before it was thought that the thickness of the calcium matters. Now it is being slowly understood. Thickness matters less. The density of the calcium matters more. And when we have the photon CT, that may further help in using the appropriate therapy. This is our own case where we did the pillowing more to break the nodular calcium, that we will see later. So this is the case example, one case. 75-year-old male had a previous PCI 10 years back, middle area in OM, now had a new effort angina, and check angiogram showed patent stents. Both the LAD and OM stents were patent. In between, the patient underwent a radiotherapy for a thyroid carcinoma. So after 4-5 years, he has developed this lesion. So radiotherapy also may have contributed. And the check angiogram showed a non-eruptive calcified nodule in the ostium of the LCX with some extension of the lesion in the left main, distal left main, and the LAD. So this is the baseline angiogram. We can see the distal left main block. We can see the haziness in the ostium of the LCX, and the LAD stent and OM stents here are patent. So this is the cranial view, just to show that there is a distal left main extension of the lesion. And RCA was quite normal. Also, this is the baseline. So we have the lesion here, some lesion in the distal left main and extending into the LAD also. So our plan was to have an IVL, either left main to LAD provisional stenting, or if the 2 stents requirement is there, depending upon the IVS, we can go for the 𝐑𝐞𝐚𝐥. So we took a check shoot. We were able to cross with 2.5 millimeter balloon, and then we did this IVS. So we can see the calcified nodule in the 12 o'clock position here in this view, and we can see the calcium extending down also, and we can appreciate in this column also. So there is multiple levels of 270 degrees to 360 calcium, and also that the ostium of the L6 had this typical calcified nodule. And this is the pillowing of the IVL. We can see that we are able to, but the first thing is we should be able to pass the balloon smoothly. We should not rupture the balloon, and the balloon rupture happens mostly if you go at 4 atmospheres. And it has been documented in multiple registries that going at 2 atmospheres, delivering the therapy, cracking the calcified nodule, and then going to the higher pressure of 4 atmosphere is better. This 4 atmosphere is not a nominal pressure. This pressure is the one which creates the ideal fluid medium when there is a space. But when there is less space, we should start with 2 millimeters, and when we are taking a bigger balloon also, we should go with the 2 atmospheres pressure, and then we can build up to 4. Conventionally, we have been doing at 4, and then we are going to 6. So that can be avoided in nodular calcium, specifically to make sure the balloon does not get damaged. So we move with the multiple pulses. We can see that this we have broken the modified the calcium as seen in the right hand side of the screen. From this we have come to this, and the pulse management is also important. We have to make sure that we give the pulse first, exhaust the pulse at the where we want. and then we extend to the IVL to the distal also. We had a good expansion of the balloon, and we also did to the distal left main. And there was in the IVS showed a area of less than 4 millimeters in the distal left main, and also in the osteal we had a lesion, so we went for the double stent technique. This is the post IVL check shoot, where we can see little bit of the lumen gain even in the angiogram, and also in the post IVL post IVS check also had a lumen gain of 2.75, which was less than 1.3 at the starting of the therapy. So then we went with the usual 𝐑𝐞𝐚𝐥 load, so left main to LCX, a pot, and then rewiring into the, after the pot rewiring into the LAD, the rewiring is always distal in 𝐑𝐞𝐚𝐥 load, so this is the rewiring, and then after the rewiring we will have the, this is the distal rewiring, and this is the first kissing inflation followed by left main to LAD, pot, and then the again rewiring into the LCX, which is always again distal, and then opening the struts, and then two-step kissing inflation, individual balloon inflation followed by the kissing inflation, and finish with the third pot. So multiple pots to make sure we get the appropriate therapy. This is just to show that we have the good left main apposition, but we always should understand that even with all these therapies, we can see that the LCX ostium is still constricted. Although we had a lumen area of 5.32, even the longitudinal view we can see that this is the area we had the almost constricted view. So even downstream we had a bigger areas. So this is always the problem with calcified lesions. So at least we should aim for reasonable vessel expansion to get the things done. So this is the final result. Angiographically we had a good result, 𝐑𝐞𝐚𝐥 load. This is the caudal and the cranial views, and this is the area where we started with, this is where we ended with. So my take home will be two parts. One is, usually when we use the IVL, the IVL best practices are we should make sure this is an IVL catheter, it's not an IVL balloon, so deliver at lower pressures is not a harm, and balloon sizing and inflation has to be modified according to the lesion. If it is a bifurcation lesion, if it is a nodular calcium, we may have to slightly oversize and inflate higher pressures. Pulse management always important. Exhaust your pulse are the most wanted area. Stent boost and emitter placement is very important when you are dealing with non-concentric calcium, because in bifurcation and nodular calcium you always have to make sure the emitter placement is good. Always DR before, and the safety profile is good. That is why IVL is being recommended in these kind of situations. So specifically in calcified nodule, if you are having a very difficult calcified nodule, don't hesitate to oversize by 0.5 millimeters to get the pillowing effect. Inflate initially 2 atmospheres so that we modify and we have a fluid medium, and then we can move up. Balloon should be advanced distally and withdrawn at 2 millimeters overlap to make sure that emitters are covering the entire base and the limbs of the nodule. So nodules have the base and limbs, ascending and descending limbs. The weakest part will break, so we have the weakest part, we do not know where it is. It depends upon the density of the calcium, and we have to cover both the base and the limb, and pulse management is important. If we can use appropriately, we can tackle non-eccentric calcium, specifically calcified nodule also with an IVL based therapy. Thank you. Open to questions.
Hello. Yeah. Nice presentation, Karizan. There is an interesting concept of billowing effect. Just oversizing the IVL balloon and keeping it at low atmospheres. It's a very interesting concept, and also the reason 𝐔𝐧𝐩 consensus statement says that you don't need to go up to 6 atmospheres. You can keep it at 4 atmosphere. After once the shock waves are done, then you don't need to go for a 6 atmospheres and prolonging the time of inflation. Sometimes with a hemodynamically unstable patient, you can't keep the balloon up for a long time. That is the statement given. Unlike in the traditional practice, after the 4 atmospheres, we will again thinking that the emitters will damage the balloon, will go up to 6 atmospheres. That is not necessary nowadays. And the pillowing effect is a good concept for nodular calcium. Any comments from Dr. Madan, Dr. 𝐸𝐥𝐝, and others?
Yeah, good presentation by 𝐤𝐧𝐩𝐥𝐝, and all slides are very nice. The one thing I like to share with you, most of the time I faced a problem with the nodular calcium. So that time what I used to do with my experience is, I go little bit 2 atmosphere, like from 4 atmosphere to 6 atmosphere, I keep the balloon so that it touches the calcium nicely and breaks the calcium. That is what my theory worked most of the time, and I used to break the calcium. So earlier times, we used to think we may not be having that orbital atherectomy in our lab. So that time the struggle will be there. So this proportion I was handling with the 6 atmosphere, I used to break the calcium. So nicely the calcium also will break, and we used to put the stent and come out. This is my experience which I faced with all the nodular calcium.
Good, great. Any other comments? So, for all the participants.
So I think Madan Mohan sir's point is also well taken. So the idea is whenever you're having a 1:1 balloon sizing, you will be going at 3 to 4 atmospheres, and then after at one point you will be going to the 6. But in the pillowing concept, you are actually oversizing the balloon. So that's why we go at 2 or 3 atmospheres and then go to the finally at the 4 to get the best effect. So either one of these strategies are good, but nowadays the concept is slowly moving towards in calcified nodule toward this pillowing effect concept, sir.
And one more thing, what I did is double balloon technique, where I used to keep a normal balloon along with the IVL balloon. With that, we can the space will be narrowed and we can hit the calcium even better. So only thing we should be carefully doing it. But that time also I succeeded with the 2-3 cases with the double balloon technique.
Was the balloon IVL or one normal balloon?
Normal balloon.
So basically the double balloon concept is we can approximate the IVL balloon to the calcium, but the problem is sometimes the 360 we will not know where the calcium is, so sometimes we may end up harming ourselves. So this concept of pillowing will help without the double balloon, sir. So we can start doing this technique to adapt to the calcified nodule.
For the bigger size vessels, previously they used to do this double balloon. The challenge is we do not know where the energy is being utilized, whether on the nodular and the non-nodular area. That is the problem. Maybe we have to rotate the balloon so as to assume that at least in one shock, one pulse, the IVL balloon will be on the calcified nodule. But basically, I mean, in my experience, IVL, though it is a very helpful and a bailout device in a calcified nodule, and many times you see you can achieve the MSA and good stent opposition, and the OCT, the pooled analysis from disrupt CAD OCT substudy showed that almost the midterm 2 years follow-up is reasonably good. But still, I feel that IVL alone may not be the great device in the severe nodular calcium, because whatever the studies, they were underrepresented, almost like less than 20% of the overall sample size in this disrupt CAD has this nodular calcium. So it is better always if there is a device synergy kind of atherectomy followed by IVL. Unless the patient is very sick, there you feel that the atherectomy may harm the patient by slow flow and other things. Otherwise, it is better always to do a atherectomy in nodular calcium, and then not a eruptive nodule, nodular calcium, and then you can use IVL, because sometimes the IVL also fails in severe nodular calcium, and many times we will end up with a suboptimal stent expansion. And once the stent is put in, then we don't have other choice. We have to go with the OPN or laser. That is the issue. So if you feel that the calcium is really, having a high calcium burden or high calcium volume and nodular calcium, better to do a atherectomy and then go for an IVL. This is my personal experience, and a few of the cases of mine, I was not very happy, though the MSA was not achieved, but the overall appearance of the post PCA imaging was not satisfactory. So that is also there.
Yeah.
Any comments from others? Yeah.
I fully agree with Dr. Damodaran. So specifically when you are choosing the therapy, we should be clear in the upfront itself, because once if you have a dissection and then issues, then you cannot you won't be able to use the orbital atherectomy. So specifically in lesions, first is your angiographic picture itself will give us a clue, and then sometimes the imaging catheter can pass, and imaging catheter can give us a clue where we have to use appropriate therapy. It is always the device synergy, and the concept is previously, the important concept is previously it has been specifically the perception is non-eccentric calcium IVL was not useful, but that perception is slowly going away, because in multiple centers and multiple cases we have seen that IVL is able to modify the calcium nodule. But like other devices like orbital atherectomy also has to be kept in mind when choosing the appropriate therapy right from the front is very important.
And one has to all have to, the last slide take home is very important, like at least we need to match the 1:1 sizing, and many of the failures are basically due to the undersizing of the balloon. We usually have the tendency to size the balloon to the lesion diameter rather than to the lumen diameter, but the reference lumen, we have to choose the balloon to the reference lumen diameter 1:1. That is the bottom line of success in IVL. Many of the failures were due to undersizing. And also the emitters, how to place the emitters based on the stent enhancement, stent boost. That is also very essential, and a very trivial point, but still it is very useful. Is like you have to make sure you have to completely de-air the balloon. If there is an air, the energy will be dissipated by the air bubble within the balloon. So you must make sure that there should not be any air within the balloon. These are the last slides are very important for best practice in IVL. Yeah, that is also there. And one more point to add is unlike in concentric calcium, in eccentric calcium, you have to. This is a very common thing. Everyone is aware. I just want to reemphasize. You have to give repeated shocks sometimes over the nodular calcium or eccentric calcium, unlike in the concentric calcium. You cannot just go away with 1 or 2 shocks, and you have to give 3-4 cycles or even 5 cycles. At times you have to exhaust the whole thing. Again, that the pulse management is very essential, and you need to identify by imaging which are all the areas you have to focus by delivering these pulses appropriately. Any comments from other guys like Stalin and Selva Ganesh is there? Give your experience on IVL. You people are doing regularly IVL.
Sir, good evening, sir.
Mohammed, yeah.
Yes, sir. Sir, my question is to Dr. Kadirasan, sir. Regarding the oversizing of the balloon, do you recommend only for nodular calcium, or is there any other scenarios, sir?
So it is mainly for nodular calcium and sometimes bifurcation lesions. In other areas like concentric calcium, it is 1:1. There is no need to oversize. But specifically in nodular calcium, when in doubt, you have a 0.5 millimeters. Anyway, you are going to do the imaging. So either you take 1:1 and then you can have a pillowing effect even with 1:1 also. Or you can increase by 0.5 and go at lower atmospheres. The important thing is the balloon sizing is not going to be an issue. It is not going to cause a harm. The balloon sizing, if it is undersized, you will not deliver appropriate therapy. If it is oversized, it will deliver appropriate therapy, but it will never harm the softer tissues. So, but the initial inflation should be at lower atmospheres. We should not go at 4 atmospheres. That is the only thing. So, it is specifically for nodular calcium.
Okay, sir. Sir, one more thing is like when we have a long LAD lesion where we have a discrepancy in the size in the LAD, like proximally we have a larger vessel and distally mid to distal will be smaller vessel. So that time the sizing, we might be tempted to use another balloon, but it's quite costly, as you know.
Yeah.
So we end up using a single balloon. Which do you prefer, sir? Like you.
So it is a very important question. So initial days when we are in the initial learning period, we used to take a balloon matching to the distal vessel. But now all the registries and studies are very well documented that we have to, for example, if the distal LAD is 3 and if your proximal LAD is 3.5, you take a 3.5 balloon, make sure you have a way to for the balloon to go. So you have a good 2.5 balloon going in, dilating and coming out. Take the proximal reference area balloon. So I will take a 3.5 in a LAD with the proximal 3.5 distal 3, and I will use the 3.5 balloon at a lower pressures distally and then come back and do it at the proximal. Another important thing is, like Dr. Damodaran said, your pulse management. So normally what we do nowadays is we use an 1:1 NC balloon, inflate and see where there is an underdilatation and mark that point, and then there we deliver the pulse and keep the emitter there so that you do not exhaust a pulse at a non-wanted area. So pulse management with an appropriate size NC balloon, mark the area where there is an underdilatation, where there is a underdilatation of the balloon, and use the IVL. And always the answer is we can take the proximal reference.
Thank you, sir.
And also, I just want to add one more point. Just we should never, in any point of time, we should never try to match the device to the lesion. Rather than we should match the strategy to the lesion. Means if there is a diffuse disease, obviously you can't use 2 or 3 balloons. Say, for example, if you have a 30 millimeter or 40 millimeter lesion, obviously you may not be able to go away with even with your one balloon with a low atmosphere. So ideally, you have to go for an atherectomy in a diffuse disease. And obviously, in a diffuse disease, the distal vessel will be very small, wherein you cannot have any other device except a rotational atherectomy, which can help you. So always, your strategy should be to the lesion rather than based on the preconceived notion of the device per se. So if there is a diffuse disease, I would always prefer to go for a rotational atherectomy. Wherever there is a focal area of nodular calcium, then you can utilize the energy of IVL in that area. That is the best strategy to go ahead. Yeah. With that, I think if there are any more comments or questions, welcome. Otherwise, we can go ahead with the next speaker. Are there any comments? Can we go ahead with the next speaker? Dr. Madan. Madan is there. So we can go ahead with the next speaker, IVL, no surgical backup record, Dr. Mohammed Aziz. Please go ahead.
Sir, can everyone see my screen?
Yes, please go ahead. Yeah.
Okay. So good evening to one and all present here, to the dear respected chairperson and panelist. So my case here is an LMLAD CTO image guided PCI. May not be an ideal case for an IVL, but this was my first case, so it was better to start off with such cases. That's what I felt. So my patient is a 58-year-old gentleman. He presented with accelerated hypertension and angina, and ECG and echo were normal. Troponin was negative, but I suggested TMD and it was strongly positive. So angiogram was done, and this was his angiogram. So you could see LCX, there is a discrete tight lesion in the proximal segment, and distally also there is a lesion in the LCX, and it is supplying retrogradely the LAD. LAD, there is some antegrade flow also through the tight mid LAD segment, and angiographically we could appreciate some calcium over there at the diagonals. And the LAD, the lesion was diffuse and it was extending till the ostium of the LAD. The angle was favorable for a provisional single stent strategy, since there is no lesion in the ostium of the angiographically, there was no lesion in the ostium of LCX. So syntax score was done, it was 21, and the recommendation was either PCI and CABG patient preferred PCI. So the plan was to go ahead and do the LCX plasty first, and then go ahead with the LMLAD. Keeping in mind that LCX is supplying the LAD also, I had to first initially pre-dilate and create a TME3 flow in the TME2 or 3 flow in the LAD, and then go ahead with the LCX plasty. So first I wired the LCX, I tried to wire with the workhorse wire in the LAD, but that one particular point I could feel gritty feel there because of the calcium, and the wire did not cross. So I went ahead with the balloon support, and the wire crossed after that. Then I did pre-dilatation with a 1.5 balloon at 6 atmospheres and created a TIM3 flow in the LAD and went ahead with the LCX plasty. Subnominally, I dilated the distal lesion with 2.2512 NC balloon, and then went ahead with the decided to do a drug-coated balloon distally, and proximally I wanted to stent. So after drug-coated balloon, then I went ahead with the proximal lesion plasty with a 328 drug-eluting stent and post-dilated with 3.512. And this was the final result on the right side. It was there was some haziness in the distal LCs, but there was TME3 flow, and I went ahead with proceeding with the PCA to the LAD. Now this is a IVS of the LAD. In the mid LAD segment, there was no disease there, surprisingly, and this is where I wanted to land. Coming more proximally, we could see more fibrocalcific plaques and some balloon-induced dissections at the 6 o'clock and 6 o'clock to 9 o'clock positions. And more proximally, I could see the vessel lumen was, the vessel diameter was only about 2.25 to 2.5. And coming more proximal, I could see more fibrocalcific plaques here. And this region, I appreciated some 2 to 3 quadrants of calcium. And at the level where the diagonals came, there was more of this region, more of 180 degree to 270 degrees of calcium. And beyond the diagonal, the vessel almost grew in size, and it was about 4 mm in dimensions. And here also there was some fibrocalcific plaques, and here we could appreciate more of a circumferential calcium. And coming more proximally, the lesion extended till the ostium of the LAD, and the circumflex ostium is here, and it was free of disease. This was a distal left main. So my strategy was to go ahead with mid LAD stenting. The length of the lesion was about 48 mm, and distal LAD was the diameter was 3 mm, and the proximal overlap stent was about either 3.5 or 424. So we went with preparing with the lesion, because I felt either of the calcium modification was required. I work in a single cardiology center where there's no surgical backup. So with the dissections already done with a semi-compliant balloon, I felt we could go ahead with 2.5 IVL. As Kadirisan said, we had to use 1:1, but when I saw the mid part of the LAD segment at one point, it was only 2.25. So I wanted to take only 2.5 balloon, but it was not sufficient for the proximal. But main thing, as the previous speakers mentioned, that the point where there was more waste and where I need to deliberately give more impulses was the bend, especially at this point. Um, So at this point, I wanted to deliver more pulses there. So almost 80 pulses were delivered at that bend, especially at that diagonal region. So after IVL, patient developed some pain because of some nasty dissections at the mid LAD. You could notice there. Probably the dissection was extending below. I didn't want to extend, so I could not do a immediate post imaging. So I went ahead and stented that mid LAD segment with a 348 drug-eluting stent, and approximately I stented a 3.524 drug-eluting stent LMLAD. Post stenting, the 𝐷𝐐𝐝 was good, and I went ahead and did a 5/8 NC pot there. Post pot, still the 𝐷𝐐𝐝 was good. LAD, I post dilated with distally 312 NC and 3.7512 NC for the proximal LAD. And post dilatation, there was no under expansion noted angiographically. The balloon expansion was good. And after post dilatation, this was the final IVUS. IVUS, the distal landing of the stent was perfect. It was in this region, uh, normal segment. And then I'll just run through it. I could not notice any cross under expansion of the stent, and I measured areas were satisfactory. And these were the areas which were measured. The distal LAD, it was 5.4, mid LAD it was 8.5, and the ostial LAD, where we had a significant lesion, it was well expanded, 9.3. Left main stent was well opposed and well expanded. And this was the final result. Finally, I even looked at the distal LCX, that lesion was holding on to it, and DC. I felt that I think we should not do anything else beyond this. And this, concluding here, IVL or other calcium modification devices in a single cardiologist center is actually a boost. Actually, is a boon, actually, because to handle with other complications, we need surgical backup, and even like mechanical circulatory support is not available here. So I felt IVL was a better option here. To start with, I chose a less complicated case. So selection of case is also very important, especially as Sir said, like a long diffuse lesion and a very small, CTO and balloon uncrossable other atherectomy devices is the first choice, where no other, IVL is not an option there. Maybe it could be added on to an atherectomy devices. And this device should be used with a lower threshold, especially in my center, in my such centers like where I work, because of the safety of the device. But at the same time, the cost is quite hindering us to use it quite often. Thank you. I'd like to take any questions.
Dr. Madan, and a very well done case, very well managed. Is in a center with no surgical backup. This is the way you have to do it, because safety comes first, then rest. And in fact, that is the challenging thing. That is, cost is the challenging thing, but definitely you have done a wonderful job. And in fact, the distal vessels are maybe under perfused because of the tight lesion or SCTO, whatever it is. So it may look a little smaller also, but otherwise, it is a very well done case, and you have planned meticulously, opened up the LAD and then switched over to LCX, completed the LCX, and you took IVL. That is the way to go out in a place where we don't have much backup services. And IVL, the complication rate in IVL, even the disrupt CAD1 to 4 pooled analysis is less than 0.5%. In fact, I have not heard any perforation as such from IVL. So in that, or slow flow or no flow. So the safest device to use. Dr. Madan and Kadir, any comments to be added?
Yes, sir. I think very well done, Mohammad Aziz. I think whenever this is the way we have to plan, depending upon the resources we have to plan, like Dr. Damodaran said, very well done case. And IVL, since it causes it's very safe to the softer tissues. It just passes off the softer tissue. So that's why the safety of the IVL is being demonstrated. The good thing is you were able to, I think the whatever the dissection you had, was after whenever you are doing the IVL, during the IVL you had the issue, or after sometimes before the IVL you did the NC balloon. At the time, where was the issue?
No, sir. Actually, the previous first NC semi-compliant balloon I used, that caused initially that I wanted it to create a TIMI3 flow first. That time itself, there was some dissection. But
Okay.
patient was totally asymptomatic. Once after IVL, maybe the dissection was, it extended
Basically,
and
there
got
was a
worse.
dissection before taking the IVL, and because we had
Yes.
the IVL therapy, there was some there was some flow occlusion, and then the longer balloon inflations would have caused a slow flow. That's correct. So you have managed very well. This is a way to do it. Congrats. Yeah. Thank you.
Thank you.
Any other comments?
I have one question, sir.
Yeah, please.
In case you have an abrupt closure of the vessel, will you go ahead and then stent the vessel, or like you repair the lesion with well?
Sorry, we didn't get you properly. Meenakshi, can you please come again?
No, if you have an abrupt closure after an IVL balloon inflation,
Yeah.
do you go ahead and do a stenting, or like you will prepare the lesion very well with the NC and then like go ahead?
No, then if we have done an IVL and if we have given appropriate shock, it is understood that it might have already cracked the vessel if we have done the sizing well. And in fact, you see, I mean, there are, and I can extrapolate the other finding to this to answer this question. That is, some of the IVL cases, if you do a post-IVL imaging, you may not see a fracture. But you need not worry about that. Even if you don't see the fracture, you need not worry about that. It's understood that there are some microfractures.
The landing zone
Speaking on
relaxed and that will be safe. Actually, just
okay. So if you if you do a post PCA, post IVL imaging, you may not see any fractures. But on bench studies, it has proven that there are microfractures by the micro CT. There are fractures on the in the treated vessels after IVL. So what I am trying to say, if you have done a IVL with a proper 1:1 sizing and given adequate shocks, it is understood that you have already prepared the vessel. And that situation, if there is an abrupt closure, obviously there is a ST takeoff and ST elevation, patient is becoming unstable. Obviously, we need to stabilize the patient. It is nothing wrong in putting the stent and stabilize the patient rather than allowing it to go for a BT or BF. And if you have not given adequate shocks, obviously, as you rightly pointed out, we need to do further preparations. Yeah. Aziz, what is your comment on that?
Yes, sir. Sir, regarding whatever ma'am's question was, she was actually mentioning if there is any acute closure, should we still waste our time on preparing the lesion, or should we salvage it? Obviously, I think we have to restore the flow for the vessel. That is the first priority by stenting the vessel. And then if there is any under expansion, we could even manage later. Even I think IVL is option even after post stenting. I think for under expansion we could do it, and we can even use higher pressure balloons like OPN and other balloons for under expansion. But definitely we cannot wait if there is an ischemia going on. Just for preparing the lesion, I think we should first prioritize for the ischemia.
Yeah, it's a real challenge, whenever you are doing the case when the patient is having a complete occlusion of the vessel, obviously you need to maintain the patency immediately. Yeah. If there are no other questions, we can go ahead with the next speaker, Dr. Stalin Roy. Please go ahead.
Thank you, sir.
Good evening to all. I would like to thank Translumina for this opportunity. I'm trying to share my screen. Let me see. Yeah. Okay. So slides are visible?
Yes, sir.
Yeah.
That is right.
Okay, sir. So already Kadresan sir has dealt with this how to approach a calcific nodule. So that has made my job quite easy. I'll skip all these theory part and directly go to my case. But before that, I would like to just reinforce one the pooled analysis of the DISC CAD trial. And here they found out that one interesting was that most of the eruptive nodules tend to get softened with IVL very easily, but there are certain nodules like around 20 to 30% of nodule which may not give way. But despite that, we'll get a good luminal area, luminal gain. So most of the times the IVL will be effective in achieving a good luminal gain. But if you have a lesion where we cannot cross it with a balloon, then we have to go for other atherectomy device and then subsequently use the IVL for getting a good luminal area. That is the crux of this data, the study done by 𝐔𝐧𝐩𝐥𝐝 and all. Right, I'll go to my case. 64-year-old male presented to another hospital with unstable angina, old inferior MI in 2003. Post CAG was done at the time, CT of LCX, but was kept on medical management. And at present, his echo showed RWMA with EF of around 35%. And we took him up for CAG, which showed a triple vessel disease. He was advised CABG, but however, he was not willing for CABG. So this is the angiogram. You can see that heavily calcific vessels. You can see a nodule sitting in the left main, the shaft of the left main. Also, we can see that the circ distally, it is totally occluded. And there was a significant calcific disease in the LAD also. And this is the RCA. RCA was also had a CTO, but it's a codominant system and well collateralized. We did a nuclear stress imaging, which showed that non-viable territory in the infralateral segment. So basically, only the LAD territory was, LAD and OM territories were viable. So we thought we'll try to salvage that portion and plan for a IVL assisted PCI. So routine steps, wiring both the vessels, preparing the distal lesions. Initially, there was a lesion in the diagonal also that I just wanted to balloon and open it up just to keep it flowing, and then worked with the circumflex. Didn't go and touch the CTO of the LPLB because that area was already scarred. But I had to open up the OM because that area was quite viable. And this is the initial IVS run. We can see that there was significant 360-degree calcium in the LAD, especially near the diagonal ostium. And the proximal part also had nodular calcium. And coming to the left main, we can see two nodules, both in the opposing walls in the left main, significantly narrowing the lumen, causing almost like a slit-like lumen. So this will be a difficult case for IVL because, as you know, that when you have such a significant nodule, the chance of opening up will be less. But since he had a significant LV dysfunction, we didn't have any other option but to go ahead with IVL. Okay. Yeah, okay. So my slides were stuck. Sorry for the delay. So the lesion, we took up the IVL, but unfortunately we had only the C2 plus, C2 at that time. C2 plus was not launched. The case was done almost 3 years back. The C2 ruptured at 65 pulses. So 15 pulses could not be delivered. And one mistake which I did at that time was, as Damodaran sir was telling, I used to inflate at 4 atmospheres, deliver the pulse, and then increase to 6 atmospheres, then deflate. This had caused some damage to the balloon and it ruptured at 65 pulses. But IVL had almost done the job because after subsequently I did a pre-dilatation and I mean, it showed good expansion of the lesion area. So I went ahead and started stenting. Initially stented the circumflex into the OM and then proximal circumflex. The strategy used was the crush technique. So the circumflex stent was crushed using 4 into 8 millimeter stent. And subsequently, LAD was stented with 2 stents. Okay. Pot was done, recrossing, kissing, repot. And this is the stent boost image after the repot. We can see that there is some amount of moth-eaten appearance after the kissing balloon and repot. And on careful inspection in the IVS image, we can see that there is no stent coverage in the mid part of the LMCA. That means that stent had fractured because of the very high inflation pressures. You can see there is no stent coverage in this entire area of LMCA. So I was left with no other option but to do another stenting. I took a short 4 into 8 millimeter stent, deployed, and then post-dilated with at 26 atmospheres. And subsequently, I had to redo the kissing balloon inflation, even though the stent didn't come into the ostium of the circumflex, but I wanted to make sure that the carina was good. So I did the kissing balloon inflation, and this is the final result. And we got good areas overall. Only part where there was borderline areas were at the mid LAD, where the area was around 5.6. But overall, even the LMCA part where there was opposing nodules opened up well. And these are the final results. I'll quickly do one more case. 68-year-old male presented with unstable angina. He was a known CAD patient post PTCA in 2011, 16, and 2023. And echo showed RWMA with the EF of 39%. So this is the angiogram. Angiogram was done outside. I couldn't get the images. So this is the dual injection taken from bilateral axis. You can see that there is a CT of the RCA and some amount of ISR in the LAD and the circumflex stent. So this time I wanted to fix the RCA first because that was a culprit. So went ahead and started the RCA PTCA. The wiring was quite straightforward. Used a GaIA-Next2 wire with microcatheter support. With the help of the contralateral injection, I was able to negotiate into the distal true lumen. And subsequently, I took a 2 millimeter balloon. The 2 millimeter balloon crossed, and we can see, but there was a significant amount of waste in the balloon. You can see that there is a significant waste even at 26 atmospheres. But after the 2 balloon, no other balloon was crossing. I was quite skeptical of using atherectomy because this patient had a stent in the proximal RCA. I don't know whether it is visible or not, but there is a stent in the proximal RCA, and this lesion was just beyond that stent. So taking an atherectomy inside the stent in a patient with the LV dysfunction is quite dangerous. So I thought that I will try to do IVL, but the challenge always was that the IVL may not cross because a larger balloon was not crossing. So what I did was the inching technique, that is to keep the IVL at the mouth of the lesion and deliver the shock. And gradually, once the lesion softens up, we can open it up with a NC balloon. That was the plan. I delivered 4 pulses at the mouth of the lesion. And subsequently, we can see that with the help of a guide plus, we can a 3 millimeter balloon was able to be delivered, and it opened up well after high pressure inflations. And this is the IVS. Initially, IVS didn't cross. You can see that there is a tight nodular calcium just after the stent. That is a stent. And after the stent, we can see that there was a significant nodular calcium. But with the IVL, we were able to achieve good luminal gain. And subsequently, stenting. 2 stents were used. And this is the final result. Final IVS, good areas. And this is the final. This is the final result. We got a good area in the RCA. The LAD and L6 was staged for a later date. Right. Case 3, again, this is a nodular calcium. Balloon uncrossable, did rotablation to cross. For want of time, I will try to skip. And stented. So IVL is useful in most of the scenarios, but except in balloon uncrossable lesions. Right. Okay.
Nice case, Dr. Stalin. I have a question for you. The first case, it was like a severe LV dysfunction, and you wanted to, you have deployed a IVL in the left main. So, what was the precautions you took? How did you manage the case?
So I had MCS IABP backup, but apart from that, one thing which I did was that for the initial few pulses, I gave all the 10. Patient was tolerating. But subsequently, there was a BP fall with every inflation. So what I did was I just gave 5 pulses and deflated. That was also one reason why the IVL balloon rupture. If you don't give time for the balloon to cool down before deflating, what will happen is the balloon will get heated up and it tends to rupture easily. So that is one way we can give IVL pulse without causing significant hemodynamic compromise.
Yeah, for the second case, I think you did like a kind of a granuloplasty kind of, you are just inserting the IVL and doing it. You don't have that, you may not have that challenge when javelin IVL.
Yes, sir.
Of course, we have to get the javelin IVL. So in that, it will be easily tracked through the tightest lesions or CTO kind of things. Otherwise, wonderfully done cases, and obviously you highlighted in a compromised LV how we have to use IVL, like no short pulses, and we don't have data, but it is working out in real world practice, so we need to use that. Excellent.
Thank you, sir.
If there are no other comments, can we go ahead and do the next one by Dr. Meenakshi, Empower CAD.
Good evening, sir.
Yeah, good evening. Please go ahead.
So my topic today is like Empower CAD. So this is a real world data that empowers it's mainly an IVL first strategy that was mainly done in female patients. As you all know, that women are so much underrepresented in most of the trials, like maybe like rotational atherectomy trials or any atherectomy trials, all the trials, women are so much underrepresented. And women are diagnosed with CAD in an older age and they have more comorbidities. That is the reason, like the complication rates are very high when there is a calcified lesions, and the anatomy with small vessels and more calcium plays them at very high risk. So for these reasons, they are very much underrepresented. So this Empower CAD was predominantly for female patients. So here, like this is the real world data where you can see the procedural NACE, which is very high in females compared to the males, and the bleeding risk is higher, coronary dissection rates are higher, and tamponade rates are higher. So the Empower CAD is a prospective multi-center trial. It's a single
Excuse me, Meenakshi, the slides are not moving.
It's not moving, sir?
Yeah, it's not. I think, yeah, it's not moving.
Yes, ma'am. The slides are not moving, ma'am. They're stuck.
Then, like, I like to have Maheshwaran to share the slides.
Ma'am, I will share slides on your behalf.
Yeah, okay, fine.
Allow me 1 minute, ma'am.
Yeah, sure.
Is my screen visible, ma'am?
Yeah, visible. So next slide. So these are the reasons like why women are so much underrepresented because of their more complications. So next slide. The Empower CAD is a multi-center trial done across the world, and it's a prospective study, a single arm, and it's an all-comer study. So they were not chosen, and in this, the IVL was a first strategy. It was an IVL first strategy. So they have treated almost 399 patients, about 449 lesions, and there was a 3-year follow-up in this trial. The endpoints which they have chosen is a target lesion failure, defined as a composite of cardiac death, myocardial infarction, and target vessel attributable to target vessel, or ischemia-driven target lesion revascularization at 30 days. And the primary effectiveness endpoint, that is like procedural success, defined as stent delivery with the residual stenosis of less than 30% in the target lesions and without in-hospital target lesion failure. That was the endpoints which they have chosen. The key inclusion criteria is any patients more than 18 years who meets the criteria for who needs a PTCA to be done and who has a calcified lesion. Next slide. So in this trial, almost 45% of the patients came with stable angina and 23% of the patients came with non-ST elevation MI, and the category with STEMI was very less, 2.5%, and the cohort was more of diabetes mellitus in 46%, and prior MI in 32%, chronic kidney disease in 27.6%, and hypertension in almost 88% of the patients. Next slide. So in the Empower first strategy, so what they have done is, so they have planned the PCA, they have enrolled all the patients who met the criteria for PCA with the calcium, and once they have enrolled the patient, they have passed the IVL. So if the IVL is passed, so imaging was done prior to doing an IVL. So once the imaging was done, then IVL was going to pass. Once IVL was passed, then they have delivered the IVL strategy, and after IVL shocks, they have done a post-IVL imaging, and if they have attained good area, they have gone with other adjunctive devices and then did a stent. For patients who their IVL could not be passed, they have done adjunctive treatment like going with an NC balloons, OPN balloons, or cutting balloons, and then even IVL shocks, and then did a post-IVL imaging, and then delivered a stent. So this is the how they have approached the patients. Next. So the target lesion characteristics, patients with one target lesion was almost 87%, and patients with more than one target lesion was almost 13%. And all the patients were analyzed in the core lab, and even before also they were analyzed in the core lab, and the angiographic lesion measurements were almost lesion length of almost 33.5 and calcification length of 45 millimeters, severe calcification of 99.3%, and the minimal lumen diameter average was 0.7 plus or minus 0.4. Next slide. So in this Empower CAD trial, IVL demonstrated favorable safety outcomes in hospital and a 30-day follow-up. The target lesion failure within 30 days was 12.1%, and the cardiac death was 1.3%. The periprocedural MI less than 40 hours was 9.6%, and spontaneous MI more than 40 hours was 1.5%. Even though there was a higher percentage of periprocedural MI, it was predominantly enzyme biomarker related periprocedural MI. It was not a clinical myocardial infarction. And ischemia-driven target lesion revascularization was done in 1.3% of the patients. Next slide. So when we compared the effectiveness endpoints, almost the stent was delivered in 98.5% of the patients, And residual stenosis less than 30% was achieved in 98.5%. And patients who went out of the hospital without target lesion failure was 88.7%, having good procedural success. Next. And there was a significant improvement in the quality of life with the physical limitation score, angina frequency score, and quality of life score. They are better with plus 26% compared to non-IVL based patients. Next. So IVL has been consistently shown to have low angiographic complications. In this study, especially as Aziz told, it is very good for a beginner because we don't have much complications like slow flow, no reflow, and the perforation or abrupt closure is a very rare complication in IVL. So as a first operators or beginners, we are very safe doing with IVL. So in this study also, the serious angiographic complications has been less than 2.6%. Dissection is one major complication with IVL balloons because as we select a balloon of 1:1 diameter, obviously we get dissection in many patients. So in this study, it was almost 2.6%. But the rate of perforation, abrupt closure, slow flow, and no reflow was almost 0%. And this is like comparing with the male in the distant CAD. When you compare the post-IVL serious angiographic complication was 2.3% in the male population, and ciliary dissection was like 1.8% in the male population. Next slide. So for conclusion, like a shockwave IVL is a frontline calcium modification strategy that is safe and effective for female patients with calcified coronary artery disease. There has been studies where rotational atherectomy was done in female population, and it found to have more complications in the female arm. And in real world female patients, more complex than the distal theory cohorts, shockwave IVL maintained a strong safety profile. And IVL's low angiographic complications is now confirmed across both male and female patients. So it is a easier technique and is a very safe procedure, particularly in a very complex patient substrate like female patients. Thank you.
Thank you, Dr. Meenakshi. It's an interesting study, especially for the women subsets. Obviously, women subsets will have generally may have some lesion characteristics different from the male gender, and the results are comparable to disrupt studies. And my only question is that why this TLF is almost like 12% in 30 days, no lesion. Is there any explanation given in the study?
And there is not much of explanation given. Like the calcium has not been quantified. They have given us like 98%. I think it was a circumferential calcium or a calcific nodule. The calcium was not defined in the study. That is one reason. And they have taken us like the less than 30% as residual stenosis. So that may be another reason. They have taken it as a procedural success. I think that may be a reason for TLR.
Any comments? And any of the Empower CAD, apart from the scientific data, we need to empower all the women to be affordable for this therapy also. Because the therapy is, even now it is very expensive. Can we go to the next?
I feel like the women have very calcified and very small arteries. Like
Yes.
taking an IVL balloon into those small arteries is a very big challenge, particularly in our population, especially.
Absolutely. So can we go to the next topic, how IVL worked for me in difficult cases? Dr. Selva Ganesh.
Yes, sir. Thank you so much, sir. I am going to share my screen. Is it visible to you, sir?
Yeah, please go ahead. Yeah.
Thank you so much, sir. I think, is it visible, sir, now?
Yeah, visible. Please go ahead.
Okay. So I'm going to present 3 cases wherein I had used IVL, particularly in the left main diseases. So before going to the topic proper, let me compare the rotablation, orbital atherectomy, and IVL. These are all the points which favors IVL. IVL is a tool where it is useful even in it's like using some other balloon. So there is no much learning curve is needed. At the same time, we should understand the basics of mechanisms of IVL as well as the risk and benefit associated with the other rotablation and orbital atherectomy. And the IVL is the choice wherein a patient presenting with acute coronary syndrome with a significant amount of thrombus load. And IVL is a choice in a patient having a left main disease wherein side branch need to be protected properly, where we cannot, in rotablation and orbital atherectomy, we cannot put a side branch wire. And these are some points I want to convey. And already other things have been discussed by Dr. 𝐤𝐬𝐥𝐝 sir and Stalin sir also. Let me go ahead with my patients. So here is a 54 years old male who presented with the inferior wall MI, now came undergone a culprit vessel PCI to the RCA initially, now came for the staged PCI to LAD. He was actually suggested a coronary artery bypass grafting, but being presented with a significant pain, he was dealt with the initially culprit vessel PCI to RCA. Later, we suggested a CABG for this LAD, left main to LAD lesion, but they wanted to proceed with a percutaneous coronary intervention. Here, we can appreciate the coronary angiogram. In the caudal view, we can appreciate there is a significant amount of calcium. With this angiography itself, we could think there is a possibility of a deep-seated calcium. And in the cranial view also, you can see the calcium is extending up to the mid-LAD. So this is a LAO caudal view. Here also we can appreciate the thick sheet of calcium, which is almost situated deeply. So this is a wiring was done just to demonstrate the calcium with the wire shadow. And then the patient was taken up for the OCT imaging. Since the lumen is very free to allow the OCT catheter, we did a OCT first. This is a OCT finding of a patient recorded in the Ultrasound to imaging. Here we can appreciate there is a significant amount of calcium with a thickness of more than 1000 microns and situated deeply, and the length of the calcium is more than 5 millimeter. 15 millimeter, and the calcium angle is almost 360 degree, which we can appreciate here. And another point we made out here, the selection of the IVL balloon, IVL catheter size. Here we can appreciate the EL to EL length is almost 3.95 in the proximal LAD, as well as in the mid LAD also it is almost about a 3.7. So we could confidently take IVL size according to the OCT EL to EL. So as per law, we should select 1:1 IVL catheter size. Then only we can get a proper reach of the, shock into the particular calcium which is situated deeply inside. So in this patient, almost 360 degree calcium, thickness is more than 1000 micron, and the EL to EL almost more than 3.7. So we took IVL of 3.75 and delivered the shock almost, we took 80 pulses, and initially we delivered in the mid part of the LAD where we delivered almost 30 shocks. Then we took it proximal LAD where we delivered almost another 30 shocks. Following that, we delivered almost another 20 shocks in the in-between area. So after IVL, we could get, this is the lumen size we could able to achieve. Even after IVL, we could see there is a good amount of luminal gain achieved. Yeah, we could see the share. This is how we did it. Then after that, we took a Scoreflex balloon of 3.5 only we took here. We just want to play safely with the Scoreflex after doing IVL. We dilated it up to the 12 atmosphere, then crashed in the mid part of the area. Even there, we can see there is a slightly not yielding in the mid part of the area. Then we gradually increased the atmospheric pressure and we could able to get the good preparation. And the distal part of the lesion, there was a lesion where it was treated initially with 2.75 balloon. Sorry, by mistake, I put it as a 3.75. Then the proximal inside the left main, I took a 3.75 balloon, NC balloon, prepared to the maximum of 20 atmosphere. And with every caution was taken to assess is there any perforation, there is leakage. After dilating every time, we took a slight injection. Finally, after preparation, we took a OCT, which clearly showed a good amount of luminal area. At the same time, there is a significant amount of calcium fracture, as well as preparation success was shown by a good amount of dissection. It's not flow limiting. This is the post IVL OCT finding. Here we can appreciate the calcium cracks, and as well as significant amount of dissection, and the luminal gain also achieved. Despite that, there is a significant amount of chunk of deep-seated calcium, as pointed out by the Dr. Damodaran sir and Kadhiresan sir. It is, even though we could not see the macro fractures by OCT, we could see the micro fracture. That micro fracture will actually allow the stent to expand adequately. At the same time, we're doing a post-dilation and other things, which will smoothen the calcium to allow the good amount of expansion. That determines the long-term result. So with that amount of a good preparation, with the confidence, we took a 3.5 into 23 millimeter 𝐧𝐻 stent in the distal part. And then in the proximal area, we took a 3.5 into 38 millimeter of stent. Here we had some difficulty in tracking the stent down with 3.5 into 38 millimeter, where we took a support from the 𝐔𝐧𝐩𝐥𝐝 and dilated it. After that, post-dilatation was done with a 3.75 into 10 millimeter balloon. Then LM part was done with a 4 into 6 millimeter balloon. Then OCT was taken, which showed a very good, beautiful expansion of the stent, starting from the middle AD to the proximal AD. And there is one area where we had a under expansion, where the area is only around 4.9. So we aimed at to achieve almost 5.5 millimeter square. So we took a OPN balloon there and dilated. After OCT, after doing all these things, OCT showed there is a dissection in the proximal area. Yeah, you can see here, proximal edge medial dissection was there. And this is the area where we had only 4.9 centimeter square, millimeter square area, which was dealt in then with the OPN balloon. Here, this medial dissection, which is in the proximal area, that is in the left main, inside the left main. So we don't want to leave that as such. We took another stent, small size stent, which is covered in the 4 into 12 millimeter. See, actually, even though we thought initially in the left main ostium was relatively smooth, but since it is also having some amount of plaque which was not being detected initially with the OCT, that could be the reason. And the 𝐔𝐬𝐥 law movement would also been produced dissection which was not detected initially. Later with the final OCT, this proximal edge dissection was identified and dealt properly. So this shows the importance of the imaging to deal with all these significant complex disease. And such a complex thick calcium has been dealt very properly with IVL and showed a good amount of expansion. In this caudal view, you can very well appreciate the stent has been properly hugging the calcium which was deeply seated. Yeah, this is the final result. Here we can appreciate the nicely expanded stent. So next patient is a 75-year-old gentleman, known diabetic and hypertensive with rest angina of 1 day duration. You can appreciate the ECG showing a dynamic changes. Hence, he was taken up for the angiogram. This is a right coronary angiogram. There is a small amount of plaque in the proximal part, and it gives a good collateral into the LAD territory. And this left system showing there is a significant amount of calcium starting from the left main into the proximal and mid LAD. There is a tight lesion extending from the left main. We can appreciate in the caudal view also. Yeah, there is a tight left main, especially at the bifurcation point of the circumflex. And so now a patient presenting with acute coronary syndrome and tight left main disease with the calcium. Here, initially we tried to pass the wire. We had a difficulty in crossing into the circumflex. So we thought our aim, the patient is developing pain. We decided to go ahead with dealing with the LED immediately. So which was wired quickly. After wiring the LED, we tried to pass the balloon. Balloon could not cross into the mid part of the LED. So we took a small size 𝐑𝐞𝐚𝐥 balloon, which was able to cross into the middle part where we dilated with a 𝐑𝐞𝐚𝐥 small size balloon. After that, we took a 2 into 10 millimeter balloon and dilated with a pre-dilatation, with a little amount of pre-dilatation so that we can get the IVL balloon inside. We took the IVL balloon. IVL here we took a 3.5 mm IVL balloon and then we dilated. Here imaging was not done prior to the dilatation or IVL treatment. And then after preparing the area with IVL, we took a Scoreflex balloon. After that, the stenting was taken with the body wire support. We had a difficulty in tracking the stent. Here we used the body wire as a support to track the stent down. After that, proximal also we dilated. This is a final result. We can compare it here. So without IVL, I don't think I could have achieved such a nicely expanded stent, which is beautifully flowing LED. On the other hand, here circumflex was occluded completely, but even though patient was not having any symptoms because there was a good amount of collateral entering into the circumflex area. So this is the second patient. Then I'm taking the third patient. Here also we can appreciate this is an acute coronary syndrome patient who presented with a non-ST elevation MI. Here we can appreciate previously he was undergone a stenting to the L6, which was not flowing nicely. Then we can appreciate there is a LED ostium is showing a chunk of calcium, and with this angiograph itself, we can appreciate there is a thick calcium. It might be more than 1000 micron, and it almost like deep-seated, appearing as a deep-seated calcium, which was ensured with OCT imaging. It was done some 3 years before. It was a pre-Aldrian era. Almost we can appreciate the deeply seated calcium inside, and the calcium length also quite significant. It is occupying the bifurcation point. So we took a 3.5 into 10 millimeter IVL with the 7 pulses given at the LM to LM2 proximal LED, where there is a chunk of calcium that helped to track that area and allowing the stent to track down. Following the IVL, we used Scoreflex balloon, which is our routine strategy most of the time after doing an IVL preparation to get a good amount of block modification. After giving a good amount of microfracture, we used to prepare the lesion with a Scoreflex or adequate sized 1:1 NC balloon so that expansion can be better. So this was the final result after stenting. Here we can compare the pre-angiogram with the post-angiographic picture. So with this, I'm concluding my presentation. So to conclude, IVL is a tool, doesn't require much learning curve, which is same as that of using any other balloon strategy. But selection of the cases is most important. And if we have a imaging, which will make easy our job by selecting the size of the balloon, and so that we can avoid unwanted complication. As everyone pointed out, the complication rate is very less with the IVL balloon, and it smoothened the procedure. At the same time, there was a reports documenting the ventricular ectopics and ventricular arrhythmia, and that too ill-sustained arrhythmias, which we have come across. Only just frequent ectopics we could see, but that can be simply go away once deflating the balloon and shock was delivered. So to conclude, I have used IVL in a left main lesions, patients present with acute coronary syndrome. These are all the difficult subset of complex coronary intervention where IVL helped me a lot. I'm open for the discussion, sir.
Thanks, Dr. 𝐔𝐬𝐥𝐝. Wonderful cases, well done, and nice OCT images also. And I think you've done all complex cases. One thing is, I just want to emphasize, like when you are not able to take IVL balloon or catheter into a very tight lesion, you can take an undersized NC balloon, make a way, for the further imaging of the IVL. Similarly, even in rotational atherectomy, you don't need to be scared in using an undersized balloon. Sometimes you may not get a platform segment for a rotational atherectomy. So you need to do some dilatation to pass the bulb. So wonderful cases. If there is any more comments, any questions?
Yeah, I think very wonderfully done cases, Selvaganai. This is Dr. Kadirisan here. I think you
Thank you,
have shown
sir.
very nice cases. And two important things you have shown that to the initial learners. One is, even after doing the IVL, we should always image, and we should always try to use a NC or scoring balloon to make sure we expand the vessel, because IVL causes multiplanar calcium modification and changes the compliance of the vessel. And this vessel, whatever we are doing, next NC balloon and the scoring balloon will further expand the vessel to make sure that the stent, post-stent is very good. So that is one point you have nicely shown. Other is using the imaging after the IVL also. Sometimes we get caught one point, we may not have done the enough work. So sometimes that can be changed with the imaging also. So what is your strategy in the left main? Is there any specific strategy used during the IVL inflation?
So this patient as hemodynamically was so stable, sir. So I didn't require any mechanical circulatory support, and here only I kept a temporary pacemaker, sir, actually. So I was suspecting the patient, my one and two patients, I was suspecting he may develop some circumflex flow disturbance. By the time he may develop some heart block also. On the other hand, even inflating left main, patient may develop some bradyarrhythmias. That time I can use a temporary as the backup support. Otherwise, I didn't had any much difficulty in this patient, sir.
Okay, so usually, as we discussed in Starling Roy's cases, I could not connect at that time. So one is shorter inflations, 5 pulses, and then we can do. Other is most of the
Yes,
time
sir.
when we are most of the patients actually preconditioned. So whenever we are doing the initial balloon inflations with 2.5 NC and all, they actually precondition and then they withstand the longer inflations. So otherwise, if there is an LV dysfunction and if there is an issue, I think we should have either IABP or MCS to support. So well done cases, very nicely done. Thank you.
Sir, I want to ask you only to Damodaran sir and Kadirisan sir and Madan sir also. Sir, what about rotablation? Have you done in a patient who had initially dilated with a balloon, had a dissection, but maintaining TIMI3 flow? In such a scenario, did you ever use a rotablation? What is your take on a patient who is having a dissection with TIMI3 flow, the role of rotablation, sir?
So generally, when as Damodaran sir said, when suppose if there is an LAD lesion very tight, you could not even pass the microcatheter, or you cannot bear wire with the rota wire. Then we have done with the 1.5 balloon and actually exchanged with the wire to the microcatheter. Here there is no issue. But if you use a bigger balloons, and the lumen is like, if you have a 2.5 lumen and you are used bigger balloons, and then there is gross dissections with limitations, maybe we can hesitate. But with a smaller balloon, even if there is a dissection, the one advantage of the rota is it hugs to the wire. Unlike orbital atherectomy, it hugs to the wire. So it actually, wherever there is a wire contact, it ablates. So it will not exit the vessel. Whereas in orbital atherectomy, it has an elliptical rotation. It exits the vessel, causes a larger spiral dissections. So we have done with 1.5 balloon most of the time in the proximal CX or in the LAD, where very difficult to pass the rota wire. So with the workhorse wire or CTO wire would have crossed, but microcatheter cannot cross because you cannot exchange the rota wire. So in those situations, we have done with the 1.5 balloon and safe. It is an accepted practice. But bigger dissections and bigger balloons, if you use, then we should think twice.
Only the spiral dissection, you should not do it. Only if there is a spiral dissection, then it is risky. Up to stage C or so, you can, even with the minor dissections, you can carefully do it.
Thank you so much, sir.
With that, if there are any more comments, welcome. Otherwise, we can close the session. And there is a good webinar on calcium modification, starting with the best IVL practices by Dr. Kadirisan and the cases by Dr. Mohammed and Dr. Stalin and Dr. Selvaganai. also from Dr. Meenakshi on Empower CAD. And we have a lot of learning, especially how to do an IVL in the best practice, how to do it in the most appropriate way, and device synergy. This, I think, if there are any more comments from Dr. Kadrisan and other participants, welcome. Otherwise, we can close the session. Dr. Nishant, can you give the vote of thanks? Yeah.
Yeah, hi sir. Sir, actually, I'm from the marketing team of Shockwave IVL. So not a doctor, sir, exactly, but thank you so much, sir, for allowing me so much respect, sir. So, sir, I think there are no more questions in the chat box. So I would like to extend my gratitude to you and the entire doctor, sir, who showed their confidence in treating calcified arteries, especially the eccentric and nodular calcium. And with your practical experience, sir, it gives us more confidence to promote this therapy for the better benefit of patients. So, sir, on the behalf of Shockwave Medical and Transluminal Therapeutics, I extend my gratitude to you for taking out time from your busy schedule and showcase this therapy, that how it is well effective amongst therapies. Sir, close to many of the young cardiologists are currently watching this session. So I would like to extend my thanks to them also, sir. So thank you everyone for their time and for their confidence in Shockwave IVL therapy.
Thank you. Thank you so much.
Thank you. Bye.
Thank you, sir.
Thank you. Thank you so much, sir.